Hello, I am Dr. Owen On, and this is the second installment of the Boring Lecture Series. Our focus today shifts from the bovine rumen to the feline renal system. Specifically, we will be conducting an exhaustive review of the current status of renal biomarkers in the diagnosis and staging of chronic kidney disease, or CKD. This is a condition that affects a substantial proportion of the geriatric feline population, with prevalence estimates ranging from 10 to 35% in cats over the age of 10 years, depending on the diagnostic criteria employed and the population studied. This lecture is a technical review based on the knowledge summary published in the Journal of Veterinary Internal Medicine by Kontasai, Popper, Meyer, Mortier, Merenisen, Stamelier, Defoe, and Daminet, entitled Renal Biomarkers in Cats, a review of the current status in chronic kidney disease, licensed under CC BY 4.0. This comprehensive review article synthesizes the current understanding of both traditional and emerging biomarkers used in feline nephrology. The authors conducted an extensive literature review spanning multiple decades of research, examining the strengths and limitations of each biomarker in the context of clinical practice. Before we proceed into the technical details, it is worth noting that chronic kidney disease in cats differs in several important ways from that in dogs and humans. The feline kidney has unique anatomical and physiological characteristics that influence both disease progression and our diagnostic approach. The cat's remarkable ability to concentrate urine, for instance, means that we must use different reference values when assessing renal concentrating ability compared to canine patients. Let's take the time to discuss the disease process in cats before we delve any deeper. It is essential we understand the nuances of chronic kidney disease in cats. Chronic kidney disease, often abbreviated as CKD, is one of the most significant and commonly encountered medical conditions in feline medicine. As the average lifespan of domestic cats has increased over recent decades, the prevalence of chronic diseases associated with aging has also increased. Among these conditions, chronic kidney disease occupies a central position due to both its frequency and its impact on long-term health and survival. Improvements in nutrition, routine preventive care, vaccination protocols, parasite control, and the widespread adoption of indoor lifestyles have allowed many cats to live well into their teenage years and beyond. As a consequence, diseases that develop slowly over time, rather than acute infectious or traumatic conditions, now account for a larger proportion of morbidity and mortality in the feline population. Chronic kidney disease is one such condition, and it is now widely regarded as one of the leading causes of illness and death in older cats. The kidneys perform a range of essential physiological functions that are critical for maintaining internal stability, also known as homeostasis. These functions include the filtration of metabolic waste products from the blood, the regulation of water balance and urine concentration, the maintenance of electrolyte and acid-base balance, the regulation of systemic blood pressure, and the production of several important hormones. When kidney function declines gradually, as it does in chronic kidney disease, the body is often able to compensate for a considerable period of time. During this compensatory phase, clinical signs may be minimal or entirely absent, even as irreversible damage progresses within the renal tissue. By the time overt clinical signs of kidney disease become apparent, a substantial proportion of functional kidney units, known as nephrons, have already been lost. This delayed appearance of symptoms contributes to the challenge of early diagnosis and intervention. Chronic kidney disease is therefore frequently identified at a moderate or advanced stage, rather than at its onset. It is important to recognize that chronic kidney disease is not a single disease entity. Rather, it represents a final common pathway resulting from a wide variety of underlying insults to the kidneys. These insults may be congenital, hereditary, inflammatory, infectious, toxic, ischemic, or idiopathic in nature. Regardless of the initiating cause, the long-term outcome is a progressive and irreversible decline in renal function. The clinical course of chronic kidney disease is highly variable among individual cats. Some cats experience a slow and relatively stable progression over several years, maintaining a reasonable quality of life with minimal intervention. Others demonstrate more rapid deterioration, with escalating clinical signs and complications despite aggressive management. This variability underscores the importance of a comprehensive understanding of the disease process, including its epidemiology, pathophysiology, clinical manifestations, diagnostic evaluation, and therapeutic options. This section provides a broad overview of chronic kidney disease in cats. It is intended to establish a general framework for understanding the condition, which will serve as context for subsequent discussion of renal biomarkers, staging systems, and emerging diagnostic tools. Chronic kidney disease is most commonly diagnosed in older cats, and its prevalence increases steadily with age. Epidemiological studies have reported varying estimates of prevalence depending on the population studied and the diagnostic criteria employed. However, several consistent patterns have emerged across multiple investigations. It is generally estimated that approximately 30 to 40% of cats over the age of 10 years exhibit some degree of renal insufficiency. In cats over 15 years of age, the prevalence may be even higher. This strong association with aging has led to chronic kidney disease being characterized as a geriatric condition, although it can occur in younger cats under certain circumstances. The apparent increase in chronic kidney disease over time does not necessarily indicate that the disease itself has become more common in a biological sense. Rather, it reflects the fact that more cats are surviving to ages at which the disease becomes clinically apparent. Indoor housing, in particular, has reduced exposure to trauma, infectious disease, and environmental hazards, allowing cats to live long enough for age-related degenerative processes to emerge. While chronic kidney disease can affect cats of any breed, certain breeds appear to have an increased susceptibility. Persians and related long-haired breeds are well known for their association with polycystic kidney disease, a hereditary condition characterized by the development of fluid-filled cysts within the renal parenchyma. Abyssinians have been reported to have an increased incidence of renal amyloidosis, a condition involving the deposition of abnormal protein within the kidneys. Siamese, Maine Coons, and ragdolls have also been reported to have higher rates of chronic kidney disease in some studies, although the underlying mechanisms are not always clearly defined. In addition to genetic predisposition, a variety of environmental and lifestyle factors may contribute to cumulative renal stress over time. Chronic dehydration is frequently cited as a potential risk factor, particularly in cats fed predominantly dry diets with low moisture content. Cats have a naturally low thirst drive, reflecting their evolutionary adaptation to arid environments. As a result, they may not adequately compensate for low dietary water intake through increased drinking. Exposure to nephrotoxic substances represents another important risk factor. Non-steroidal anti-inflammatory drugs, certain antibiotics such as aminoglycosides, ethylene glycol, and plants such as lilies are well-recognized causes of acute kidney injury, which may progress to chronic disease if recovery is incomplete. Recurrent or subclinical episodes of renal injury may contribute to gradual nephron loss over time. Chronic inflammatory conditions, including dental disease and periodontal inflammation, have also been implicated as potential contributors to chronic kidney disease. While a direct causal relationship has not been definitively established, chronic systemic inflammation is thought to place additional stress on renal function. Hypertension, whether primary or secondary, may both contribute to and result from chronic kidney disease, creating a self-perpetuating cycle of damage. To understand chronic kidney disease, it is necessary to review the normal structure and function of the kidneys. Each kidney contains hundreds of thousands of nephrons, which are the functional units responsible for filtration and urine formation. Blood enters the nephron through the glomerulus, a specialized capillary network that filters plasma while retaining larger molecules and cells. The filtered fluid then passes through a series of tubular segments, where water and solutes are selectively reabsorbed or secreted. Through these processes, the kidneys regulate fluid balance, electrolyte concentrations, and acid-base status. They also play a central role in controlling blood pressure through the renin-angiotensin-aldosterone system and contribute to red blood cell production via the hormone erythropoietin. Additionally, the kidneys convert vitamin D into its active form, calcitriol, which is essential for calcium and phosphorus homeostasis. Cats are particularly efficient at concentrating urine, an adaptation that reflects their desert ancestry. This concentrating ability allows them to conserve water under conditions of limited availability. One of the earliest functional abnormalities in chronic kidney disease is a loss of urine concentrating capacity, which manifests clinically as polyuria and polydipsia. Chronic kidney disease is characterized by the progressive loss of functional nephrons. As nephrons are lost, the remaining nephrons undergo compensatory hypertrophy and hyperfiltration in an attempt to maintain overall renal function. While this adaptation is initially beneficial, it ultimately accelerates further damage by increasing intraglomerular pressure and promoting structural injury. Over time, chronic injury leads to interstitial fibrosis, tubular atrophy, and glomerulosis. Inflammation and oxidative stress further contribute to tissue damage. Once a critical threshold of nephron loss is reached, the kidneys can no longer maintain normal homeostasis, resulting in the accumulation of nitrogenous waste products and the development of systemic complications. In many cats, the underlying cause of chronic kidney disease is never definitively identified. Chronic interstitial nephritis is the most commonly reported histopathologic finding, characterized by fibrosis and inflammatory infiltrates within the renal interstitium. Other recognized causes include polycystic kidney disease, chronic pyelonephritis, glomerulonephritis, amyloidosis, congenital abnormalities, toxic injury, and ischemic events. The clinical signs of chronic kidney disease vary depending on the stage of disease and the presence of complications. In the early stages, signs are often subtle and nonspecific. Increased water consumption and increased urine output are among the earliest detectable changes, reflecting impaired urine concentrating ability. Mild weight loss, decreased grooming behavior, and subtle lethargy may also be observed. These early signs are frequently attributed to normal aging by caregivers, delaying veterinary evaluation. As a result, opportunities for early intervention may be missed. As the disease progresses, clinical signs become more pronounced. Weight loss may become more evident, and appetite may decrease. Nausea and vomiting are common, often associated with uremia and gastrointestinal irritation. Halitosis, sometimes described as a uremic odor, may be noted. Dehydration, muscle wasting, constipation, and deterioration of coat quality are also common findings. Chronic kidney disease affects multiple organ systems, leading to a wide range of systemic complications. Hypertension is particularly common and may result in acute blindness due to retinal detachment, as well as neurologic signs and further renal damage. Anemia is frequently observed due to decreased erythropoietin production and the effects of chronic inflammation. Electrolyte abnormalities, including hyperphosphatemia, hypokalemia, and metabolic acidosis, are common and contribute to clinical signs and disease progression. Secondary hyperparathyroidism develops as a consequence of phosphate retention and reduced calcitriol production, leading to disturbances in calcium and bone metabolism. Gastrointestinal ulceration may occur, contributing to nausea, vomiting, and inappetence. Cardiovascular changes may also develop in response to hypertension and electrolyte imbalances. The diagnosis of chronic kidney disease relies on a combination of history, physical examination, laboratory testing, imaging, and blood pressure assessment. A thorough history may reveal increased water intake, increased urination, weight loss, appetite changes, vomiting, or behavioral alterations. Physical examination findings may include dehydration, poor body condition, small or irregular kidneys on abdominal palpation, hypertension, oral ulceration, and pale mucous membranes. Laboratory evaluation is central to diagnosis. Serum biochemistry typically reveals elevations in creatinine and blood urea nitrogen, although these markers increase only after significant nephron loss has occurred. Symmetric dimethylarginine, or SDMA, is a more sensitive marker of glomerular filtration rate and may increase earlier in the disease process. Phosphorus levels often rise in later stages, while potassium levels are frequently low. Calcium concentrations may vary depending on disease stage and associated metabolic disturbances. A complete blood count often demonstrates a non-regenerative anemia. Urinalysis is essential and provides information on urine concentrating ability, proteinuria, and sediment abnormalities. Measurement of urine-specific gravity is particularly important, as loss of concentrating ability is an early indicator of renal dysfunction. Urine culture is recommended, as cats with chronic kidney disease are at increased risk for urinary tract infections. Imaging studies provide additional information. Ultrasonography allows assessment of kidney size, shape, echogenicity, and structural abnormalities such as cysts or mineralization. Radiography may be useful for evaluating kidney size and detecting uroliths. Blood pressure measurement is a critical component of the diagnostic workup and should be performed regularly. Renal biopsy is rarely performed in cats with chronic kidney disease due to associated risks, but may be indicated in selected cases where specific diagnosis would alter management. Staging of chronic kidney disease is most commonly performed using guidelines established by the International Renal Interest Society, or IRIS. Staging is based primarily on serum creatinine and SDMA concentrations in a stable, hydrated patient. 4 stages are recognized, ranging from non-azotemic disease with other evidence of renal dysfunction to severe azotemia. Substaging is performed based on the presence and severity of proteinuria and systemic hypertension. Substaging provides additional prognostic information and helps guide therapeutic decision-making. Management of chronic kidney disease is aimed at slowing disease progression, managing clinical signs, correcting metabolic disturbances, and maintaining quality of life. Dietary modification is the cornerstone of therapy, with renal diets formulated to reduce phosphorus intake, provide moderate amounts of high-quality protein, and include omega-3 fatty acids. Numerous studies have demonstrated that cats fed renal diets have improved survival compared to those fed maintenance diets. Hydration support is essential and may include encouraging oral water intake, feeding wet food, and administering subcutaneous fluids in later stages. Phosphate binders may be required when dietary restriction alone is insufficient. Potassium supplementation is commonly used in cats with hypokalemia. Antihypertensive therapy, most often with amlodipine, is indicated for cats with systemic hypertension. Proteinuria may be managed with angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. Supportive care, including anti-nausea medications and appetite stimulants, plays a critical role in maintaining nutritional intake and quality of life. We should take the time to recap some of the more salient points of the disease here. It is essential that you understand the foundations of the disease and why they occur before we delve into renal biomarkers. This recap revisits the key themes discussed so far, reinforcing the overall structure and progression of the disease while maintaining a steady and unhurried pace. Much of what follows restates earlier material in a consolidated and methodical manner. Chronic kidney disease is one of the most common medical conditions affecting older cats. Its prevalence increases markedly with age, and it is now considered a defining disease of the geriatric feline population. As cats live longer due to improvements in veterinary care, nutrition, and environmental management, chronic diseases such as CKD have become increasingly prominent in clinical practice. The kidneys are essential organs with multiple interconnected roles. Their primary function is the filtration of blood, allowing metabolic waste products to be excreted in the urine while conserving substances necessary for normal physiological function. In addition to waste removal, the kidneys regulate body water balance, maintain electrolyte concentrations, control acid-base equilibrium, and contribute to systemic blood pressure regulation. They also produce hormones that are critical for red blood cell production and mineral metabolism. In cats with chronic kidney disease, these functions gradually deteriorate over time. The disease develops slowly, often over months or years, and during its early stages the body is able to compensate for declining renal function. This compensatory ability masks the severity of the underlying pathology. As a result, clinical signs frequently do not appear until a substantial proportion of renal function has already been lost. Chronic kidney disease is not a single disorder with a single cause. Instead, it represents the final outcome of many different types of kidney injury. These may include congenital abnormalities, inherited diseases, inflammatory processes, infectious conditions, toxic exposures, ischemic injury, or age-related degenerative changes. In many cases, the initiating cause is never identified, and the disease is classified as idiopathic. Despite the diversity of initiating factors, the pathological changes that occur within the kidneys tend to follow a similar pattern. Functional units of the kidney, known as nephrons, are progressively lost. The remaining nephrons enlarge and increase their workload in an attempt to maintain overall renal function. This adaptive response initially preserves glomerular filtration rate, but over time it contributes to further damage. As chronic kidney disease progresses, structural changes develop within the renal tissue. These changes include interstitial fibrosis, tubular atrophy, and damage to the glomeruli. Inflammation and oxidative stress further exacerbate tissue injury. Eventually, the kidneys are no longer able to maintain normal internal balance, leading to the accumulation of metabolic waste products and the development of systemic complications. Epidemiologically, chronic kidney disease is most commonly diagnosed in cats over 10 years of age. Studies consistently show a sharp increase in prevalence with advancing age. Certain breeds appear to be at increased risk, including Persians, Abyssinians, Siamese, Maine Coons, and Ragdolls. In some breeds, this increased risk is associated with known hereditary conditions, such as polycystic kidney disease or amyloidosis. Environmental and lifestyle factors may also contribute to the development and progression of chronic kidney disease. Cats have a naturally low thirst drive and may consume insufficient water, particularly when fed dry diets. Chronic dehydration may place additional stress on the kidneys over time. Exposure to nephrotoxic substances, whether acute or repeated at low levels, can result in renal injury that progresses to chronic disease. Chronic inflammatory conditions, including dental disease, have been proposed as contributing factors, although the exact relationship remains incompletely understood. Systemic hypertension may both contribute to renal damage and result from declining kidney function, creating a feedback loop that accelerates disease progression. From a physiological perspective, one of the earliest functional changes in chronic kidney disease is a reduction in the kidney's ability to concentrate urine. Cats are highly adapted to conserve water, and this concentrating ability is lost relatively early in the disease process. As a result, affected cats often produce large volumes of dilute urine and compensate by increasing their water intake. Clinically, the earliest signs of chronic kidney disease are often subtle. Increased thirst and urination may be the only noticeable changes. Mild weight loss, decreased activity, and reduced grooming behavior may also occur. These signs are frequently attributed to normal aging rather than underlying disease. As kidney function continues to decline, clinical signs become more pronounced and more varied. Appetite may decrease, leading to progressive weight loss and muscle wasting. Nausea and vomiting are common, often associated with the accumulation of uremic toxins. Breath odor may change due to uremia. Dehydration becomes more common as the kidneys lose their ability to conserve water effectively. Chronic kidney disease affects multiple organ systems, resulting in a wide range of complications. Hypertension is one of the most significant and clinically important complications. Elevated blood pressure can cause damage to the eyes, brain, heart, and kidneys. Sudden blindness due to retinal detachment is a well-recognized consequence of uncontrolled hypertension in cats. Anemia is another common complication and results primarily from decreased production of erythropoietin by the kidneys. Chronic inflammation also contributes to reduced red blood cell production and survival. Anemia may exacerbate lethargy and weakness in affected cats. Electrolyte and mineral imbalances are characteristic of chronic kidney disease. Phosphorus retention occurs as glomerular filtration rate declines, contributing to secondary hyperparathyroidism. Potassium levels are often low in cats with CKD, which can worsen muscle weakness and renal dysfunction. Metabolic acidosis may develop as the kidneys lose their ability to excrete acid. Gastrointestinal complications are common and may include nausea, vomiting, gastric ulceration, and reduced appetite. These effects contribute significantly to decreased quality of life and can complicate nutritional management. Cardiovascular changes may develop in response to hypertension and electrolyte disturbances, further increasing systemic disease burden. The diagnosis of chronic kidney disease relies on the integration of multiple sources of information. A thorough history provides important clues, particularly with regard to changes in water intake, urination, body weight, appetite, and behavior. Physical examination may reveal dehydration, poor body condition, small or irregular kidneys, oral lesions, pale mucous membranes, and elevated blood pressure. Laboratory testing is central to diagnosis and monitoring. Serum creatinine and blood urea nitrogen are traditional markers of renal function, although they increase only after significant nephron loss has occurred. Symmetric dimethylarginine has emerged as a more sensitive marker of reduced glomerular filtration rate and may allow earlier detection of disease. Additional biochemical abnormalities may include hyperphosphatemia, hypokalemia, and variable calcium concentrations. Measurement of total protein and albumin provides information about nutritional status and potential protein loss. A complete blood count often demonstrates a non-regenerative anemia. Urinalysis is an essential component of the diagnostic evaluation and provides information about urine concentration, protein loss, and sediment abnormalities. Loss of urine concentrating ability is a key indicator of renal dysfunction. Measurement of the urine protein to creatinine ratio allows assessment of proteinuria, which has prognostic and therapeutic implications. Imaging studies complement laboratory findings. Ultrasonography provides detailed information about renal structure, including size, shape, echogenicity, and the presence of cysts or mineralization. Radiography may be used to assess kidney size and detect uroliths. Blood pressure measurement is a critical aspect of both diagnosis and ongoing monitoring. Renal biopsy is rarely performed in cats with chronic kidney disease due to associated risks, but it may be considered in selected cases where specific diagnosis would significantly alter treatment or prognosis. Once chronic kidney disease has been diagnosed, staging is performed to guide management and provide prognostic information. The International Renal Interest Society staging system is the most widely used framework. Staging is based primarily on serum creatinine and SDMA concentrations measured in a stable, hydrated patient. 4 stages of chronic kidney disease are recognized, ranging from early disease without azotemia to severe azotemia. Substaging is based on the presence and severity of proteinuria and systemic hypertension. Substaging provides additional detail regarding disease severity and helps tailor therapeutic interventions. Management of chronic kidney disease focuses on slowing disease progression, managing clinical signs, correcting metabolic abnormalities, and maintaining quality of life. While the disease is not curable, appropriate management can significantly extend survival and improve comfort. Dietary modification is the cornerstone of therapy. Renal diets are formulated to reduce phosphorus intake, provide moderate amounts of high-quality protein, and include omega-3 fatty acids. Numerous studies have demonstrated improved outcomes in cats fed renal diets compared to those fed standard maintenance diets. Maintaining adequate hydration is essential. Strategies may include encouraging water intake, feeding wet food, providing water fountains, and administering subcutaneous fluids in more advanced stages of disease. Phosphate binders may be added when dietary phosphorus restriction is insufficient to control serum phosphorus levels. Potassium supplementation is commonly required in cats with hypokalemia. Systemic hypertension is typically managed with antihypertensive medications, most commonly amlodipine. Proteinuria may be addressed with medications that reduce intraglomerular pressure, such as angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. Supportive care plays a central role in long-term management. Anti-nausea medications and appetite stimulants are frequently used to maintain food intake and body condition. Management plans are individualized based on disease stage, clinical signs, and caregiver capabilities. In summary, chronic kidney disease in cats is a common, progressive, and multifactorial condition that primarily affects older individuals. It involves gradual loss of renal function, leading to widespread systemic effects. Early detection, careful monitoring, and comprehensive management can significantly improve quality of life and extend survival. Perhaps we should pause here to discuss a key element in diagnosing chronic kidney disease, that is, azotemia. Azotemia is a fundamental concept in the understanding of chronic kidney disease and renal dysfunction more broadly. The term azotemia refers specifically to the accumulation of nitrogenous waste products in the blood. These waste products are generated as normal byproducts of protein metabolism and are ordinarily removed from the body by the kidneys through glomerular filtration and urinary excretion. The 2 nitrogenous compounds most commonly measured in clinical practice are urea and creatinine. Urea is produced in the liver as a result of amino acid metabolism and is transported to the kidneys for excretion. Creatinine is generated at a relatively constant rate from muscle metabolism and is also eliminated almost exclusively by renal filtration. When kidney function declines, these substances accumulate in the bloodstream, resulting in azotemia. It is important to distinguish azotemia from uremia. Azotemia refers only to the biochemical abnormality, meaning the presence of elevated nitrogenous waste products in the blood. Uremia, in contrast, refers to the clinical syndrome that results from the accumulation of these and other toxins, and is associated with systemic signs such as nausea, vomiting, anorexia, oral ulceration, lethargy, and neurologic abnormalities. A cat may be azotemic without being overtly uremic, particularly in earlier stages of disease. Azotemia is not a diagnosis in itself. Rather, it is a laboratory finding that reflects impaired renal excretion or altered renal perfusion. Understanding the underlying mechanism responsible for azotemia is essential for accurate diagnosis and appropriate management. From a physiological standpoint, azotemia develops when the rate of nitrogenous waste production exceeds the kidney's ability to excrete these substances. In cats with normal renal function, glomerular filtration efficiently removes urea and creatinine from the bloodstream. As functional nephron mass decreases, the glomerular filtration rate declines, and these waste products begin to accumulate. Azotemia is classically categorized into three broad types: pre-renal azotemia, renal azotemia, and post-renal azotemia. Each category reflects a different underlying pathophysiological process, and distinguishing among them is a critical step in clinical evaluation. Pre-renal azotemia occurs when there is a reduction in renal blood flow without intrinsic damage to the kidneys themselves. In this situation, the kidneys are structurally normal, but insufficient perfusion limits their ability to filter blood effectively. Common causes of pre-renal azotemia in cats include dehydration, hypovolemia, hemorrhage, and conditions that reduce cardiac output. In pre-renal azotemia, the kidneys respond appropriately to decreased perfusion by conserving water and concentrating urine. As a result, urine-specific gravity is typically elevated, reflecting intact tubular function. If the underlying cause of reduced perfusion is corrected promptly, pre-renal azotemia is usually reversible and does not result in permanent kidney damage. Renal azotemia, by contrast, results from intrinsic disease of the kidneys. In this case, structural or functional damage to nephrons impairs the kidney's ability to filter blood, regardless of perfusion status. Chronic kidney disease is the most common cause of renal azotemia in cats, although acute kidney injury may also produce renal azotemia. In renal azotemia, the kidneys are unable to concentrate urine effectively due to tubular dysfunction and loss of nephron mass. Urine-specific gravity is typically low or inadequately concentrated relative to the degree of azotemia. Renal azotemia is generally not fully reversible, particularly when it reflects chronic disease. Post-renal azotemia occurs when there is an obstruction to urine flow or leakage of urine outside the urinary tract. This results in impaired excretion of waste products despite potentially normal renal filtration initially. Causes of post-renal azotemia in cats include urethral obstruction, bladder rupture, or severe lower urinary tract disease. In post-renal azotemia, azotemia may develop rapidly and can be severe. Urine-specific gravity may vary depending on the duration and nature of the obstruction. Prompt identification and relief of the obstruction are critical, as prolonged post-renal azotemia can result in permanent renal damage. In the context of chronic kidney disease, Azotemia is typically renal in origin and reflects a sustained reduction in glomerular filtration rate. However, cats with CKD may also experience episodes of pre-renal azotemia due to dehydration, vomiting, or reduced fluid intake. These episodes may cause transient worsening of azotemia and clinical signs, even in cats with relatively stable chronic disease. This distinction is clinically important because pre-renal components of azotemia may be partially reversible with appropriate hydration and supportive care. In contrast, the renal component reflects irreversible nephron loss. Differentiating between these components often requires assessment of hydration status, urine-specific gravity, and response to fluid therapy. Creatinine has historically been the primary marker used to assess azotemia and renal function. Because creatinine production is relatively constant and its elimination depends largely on glomerular filtration, serum creatinine concentration provides an indirect estimate of glomerular filtration rate. However, creatinine concentration does not increase until approximately 70 to 75% of functional nephron mass has been lost. As a result, creatinine is a relatively late marker of kidney dysfunction. Blood urea nitrogen is another commonly measured parameter. While it also reflects renal excretory function, BUN is less specific than creatinine. BUN concentration is influenced by factors such as dietary protein intake, gastrointestinal bleeding, hydration status, and hepatic function. For this reason, BUN is best interpreted in conjunction with creatinine and other clinical findings. Symmetric dimethylarginine has emerged as a more sensitive indicator of reduced glomerular filtration rate. SDMA is released into the bloodstream during normal protein turnover and is excreted almost exclusively by the kidneys. Unlike creatinine, SDMA is less affected by muscle mass and may increase earlier in the course of kidney disease. In many cats, SDMA becomes elevated before creatinine, allowing earlier recognition of declining renal function. It is important to emphasize that azotemia reflects decreased renal clearance rather than the direct cause of clinical signs. Many of the systemic effects associated with advanced kidney disease result not only from elevated urea and creatinine, but also from the accumulation of other uremic toxins, electrolyte imbalances, acid-base disturbances, and hormonal dysregulation. In early stages of chronic kidney disease, cats may have minimal or no azotemia despite ongoing nephron loss. This occurs because the remaining nephrons are able to compensate through hyperfiltration. As the disease progresses and compensatory mechanisms are exhausted, azotemia becomes more apparent and persistent. The degree of azotemia does not always correlate perfectly with clinical signs. Some cats tolerate relatively high levels of azotemia with minimal outward signs, while others develop significant clinical symptoms at lower concentrations. This variability reflects individual differences in adaptation, concurrent disease, hydration status, and the accumulation of non-measured toxins. From a staging perspective, azotemia plays a central role in classification systems such as those developed by the International Renal Interest Society. IRIS staging relies primarily on serum creatinine and SDMA concentrations to categorize disease severity. While azotemia provides useful information about overall renal function, it represents only one aspect of the complex physiological changes associated with chronic kidney disease. In summary, azotemia refers to the accumulation of nitrogenous waste products in the blood due to impaired renal excretion. It is a key laboratory finding in cats with chronic kidney disease but must be interpreted in context. Understanding the mechanisms, types, and limitations of azotemia is essential for accurate diagnosis, appropriate staging, and effective management of feline renal disease. With this general framework in mind, attention can now be directed toward a more detailed discussion of renal biomarkers, their role in early detection and monitoring, and their integration into modern staging systems. The IRIS staging system. Foundational principles. We begin our analysis with the foundational architecture of the International Renal Interest Society, or IRIS. The IRIS staging system is the global standard for classifying chronic kidney disease in the feline patient, providing a common language for clinicians and researchers alike. This standardization is essential for comparing treatment outcomes across different studies, for communicating prognosis to clients in a consistent manner, and for ensuring that therapeutic interventions are appropriately matched to disease severity. The IRIS system was developed through the collaborative efforts of veterinary nephrologists from around the world and has undergone several revisions since its initial introduction. Each revision has incorporated new evidence regarding biomarker performance and prognostic indicators. It is imperative to understand that this system is only applicable to patients with stable, chronic disease. It is not intended for the staging of acute kidney injury, where values are in a state of flux. Acute kidney injury represents a fundamentally different pathophysiological process, characterized by a sudden decline in renal function over hours to days, rather than the gradual, progressive loss of nephrons that defines chronic kidney disease. The distinction between acute and chronic renal disease is not always straightforward in clinical practice. A patient may present with significantly elevated creatinine, and without historical laboratory data, it can be challenging to determine whether this represents an acute insult or the discovery of long-standing chronic disease. This is why obtaining a thorough history is crucial, including questions about changes in water consumption, urine output, appetite, and body weight over preceding weeks and months. To achieve an accurate stage, the patient must be fasted and clinically stable. We are looking for a persistent creatinine elevation, ideally measured on at least 2 occasions over a period of 2 to 4 weeks. This prevents a single snapshot in time from misrepresenting the patient's true renal status due to transient factors like dehydration. Dehydration can cause a pre-renal azotemia, where reduced renal perfusion leads to decreased glomerular filtration and a consequent rise in creatinine that is potentially reversible with fluid therapy. Similarly, post-renal obstruction can elevate creatinine through entirely different mechanisms. The requirement for repeated measurements ensures that we are documenting a stable, intrinsic renal dysfunction rather than these reversible conditions. The fasting requirement deserves additional emphasis. While creatinine itself is not directly influenced by dietary protein intake in the acute sense, ensuring the patient is fasted standardizes the conditions under which we are measuring. This becomes particularly important when we consider other biomarkers and when we are comparing serial measurements over time. A consistent approach to sample collection minimizes variability. The curvilinear problem, creatinine's diagnostic blind spot. We must address the inherent limitation of creatinine as a marker. Its relationship with the glomerular filtration rate, or GFR, is not linear, but curvilinear. This mathematical relationship is one of the most significant challenges we face in early detection of kidney disease. The curve describing the relationship between GFR and serum creatinine concentration is a rectangular hyperbola. What this means in practical terms is that in the early stages of disease, a massive loss of functional nephrons may result in only a tiny, almost imperceptible increase in serum creatinine. Let us examine the mathematics of this relationship more carefully. When a healthy cat with normal renal function loses 25% of its nephron population, the remaining 75% of nephrons undergo compensatory hypertrophy and hyperfiltration. These remaining nephrons increase their individual filtration rate to compensate for the lost units. The result is that the overall GFR may decline only modestly, and serum creatinine may rise by only 5 or 10 micromoles per liter, an amount that typically remains within the reference interval. By the time creatinine significantly exceeds the reference range, often 75% of functional renal mass has already been lost. Some sources suggest that up to 80% of nephrons may be non-functional before creatinine rises above the upper limit of normal. This blind spot in early diagnosis is the primary challenge in feline nephrology. It means that by the time we detect azotemia through routine screening blood work, the disease is already well advanced and a substantial amount of irreversible damage has occurred. This is particularly frustrating from a therapeutic standpoint because early intervention, when more nephrons remain viable, would theoretically offer the best opportunity to slow disease progression. Dietary modification, management of systemic hypertension, and control of proteinuria are all more effective when initiated earlier in the disease process. Yet our traditional diagnostic tools fail to identify patients during this critical early window. The clinical implication is clear. We cannot rely solely on creatinine to screen for kidney disease in at-risk populations. We must incorporate additional diagnostic modalities, including urinalysis with specific gravity measurement, urine protein quantification, and newer biomarkers that we will discuss in detail later in this lecture. Stage 1. The non-azotemic patient with renal pathology. Let us look specifically at the Stage 1 threshold. In Stage 1, the cat is non-azotemic. The creatinine concentration is typically less than 140 micromoles per liter, or less than 1.6 milligrams per deciliter. However, and this is crucial, Stage 1 is not simply a designation for normal. Stage 1 is diagnosed if there is other evidence of renal pathology, despite the normal creatinine value. This evidence might include persistently low urine-specific gravity, typically less than 1.035 in the cat, after excluding non-renal causes of polyuria and polydipsia. The specific gravity of 1.035 is significant because it represents the approximate specific gravity of the glomerular filtrate. A urine-specific gravity that is consistently at or below this value indicates that the kidneys have lost the ability to concentrate urine beyond the concentration of the initial filtrate. This is termed isosthenuria. When we encounter isosthenuria in a feline patient, we must conduct a thorough investigation to rule out other causes of impaired urine concentrating ability. These non-renal causes include diabetes mellitus, where the osmotic diuresis caused by glucosuria prevents concentration. Hyperthyroidism can increase GFR and lead to polyuria. Primary polydipsia, though rare in cats, can result in medullary washout. Hypocalcemia interferes with the action of antidiuretic hormone, as does hypokalemia. Hepatic insufficiency can reduce urea production, decreasing the medullary concentration gradient. Only after these alternative explanations have been systematically excluded can we attribute the isosthenuria to intrinsic renal disease and assign an IRIS Stage 1 classification. This often requires multiple urinalyses, performed on samples collected at different times of day, to confirm that the low specific gravity is persistent rather than a single aberrant finding. The evidence for Stage 1 disease might also include abnormal renal palpation, such as small or irregular kidneys. Normal feline kidneys are smooth, symmetrical, and measure approximately 3 to 4 centimeters in length in an average-sized cat, corresponding to roughly 2 to 3 times the length of the second lumbar vertebra on radiographs. Kidneys that are notably small, often described as end-stage kidneys, indicate substantial chronic parenchymal loss. Irregular contours may suggest cystic disease, infarction, or chronic pyelonephritis with scarring. Imaging findings can also establish Stage 1 disease. Ultrasound may reveal loss of corticomedullary definition, where the normal distinct boundary between the renal cortex and medulla becomes blurred. This finding, while somewhat subjective, suggests chronic interstitial disease. Increased cortical echogenicity, when diffuse and bilateral, may indicate fibrosis or mineralization. The presence of renal cysts, particularly in older cats, may represent polycystic kidney disease or simple senescent cysts, but either way indicate structural abnormality. Renal biopsy, though rarely performed in clinical practice due to its invasive nature and associated risks, can definitively diagnose stage 1 disease by revealing histopathological changes such as glomerulosis, tubular atrophy, or interstitial fibrosis in a patient with normal creatinine values. Stage 2, mild azotemia and the hidden progression. Moving into stage 2, we encounter mild renal azotemia. Here, the creatinine values range from 140 to 250 micromoles per liter. In many commercial laboratories, the upper limit of normal for a feline patient is around 190 micromoles per liter, though this varies somewhat between laboratories and the methodologies they employ. This means a cat can be in IRA stage 2 while still technically falling within a laboratory's normal reference interval. This is a critical distinction for the clinician. The reference intervals provided by laboratories are typically established by measuring the biomarker in a large population of presumably healthy animals and then calculating the range that encompasses 95% of those values. However, this statistical approach does not necessarily identify the threshold at which pathology begins. A cat with a creatinine of 160 micromoles per liter may be flagged as normal by the laboratory's automated reporting system. Yet that same cat is clearly in IRA stage 2 and has lost a substantial portion of its renal function. This discrepancy can lead to a false sense of reassurance for both clinician and client. The laboratory report indicates all values are within normal limits, and without knowledge of the IRA staging system, the significance of even a high normal creatinine may be overlooked. This is why it is essential to interpret laboratory results in the context of IRIS guidelines rather than relying solely on reference interval flags. In stage 2, the kidneys are struggling to maintain homeostasis. The remaining functional nephrons are working at near maximal capacity. Clinical signs are often absent, which further complicates early detection. The cat may appear entirely normal to its owner, eating well, maintaining body weight, and showing no obvious signs of illness. However, at the cellular level, the compensatory hypertrophy of the remaining nephrons is reaching its limit. This compensatory process, while beneficial in the short term, may actually contribute to progressive damage. The increased workload on individual nephrons can lead to glomerular hypertension, proteinuria, and eventual glomerulosis, a phenomenon sometimes referred to as hyperfiltration injury. Thus, the very mechanism that allows the cat to maintain normal homeostasis in stage 2 may be setting the stage for progression to stage 3. From a management perspective, stage 2 represents a critical intervention point. This is when we should be implementing renal protective strategies, transitioning to a renal-specific diet with controlled protein and phosphorus content, ensuring excellent hydration, managing any concurrent hypertension or proteinuria, and monitoring closely for progression. Yet because the cat appears clinically well, client compliance with these recommendations can be challenging. Stage 3, the failure of compensation. Stage 3 represents moderate renal azotemia, with creatinine between 251 and 440 micromoles per liter. At this juncture, the intact nephron hypothesis begins to fail. This hypothesis, proposed by Neil Bricker in the 1960s, suggests that in chronic kidney disease, the remaining functional nephrons are structurally intact and can compensate through hypertrophy and increased function. However, there is a limit to this compensatory capacity. In stage 3, the remaining nephrons can no longer compensate for the loss of their counterparts. We now see the emergence of clinical symptoms: weight loss, decreased appetite, and variable degrees of lethargy. These symptoms reflect the accumulation of uremic toxins and the development of metabolic derangements. The kidney's ability to concentrate urine is significantly impaired at this stage. While a stage 2 cat may still be able to produce urine with a specific gravity of 1.030 to 1.040, a stage 3 cat often cannot exceed 1.020, and many are isosthenuric or even hyposthenuric. This results in polyuria, which leads to compensatory polydipsia. Clients often report that the litter box is consistently wet and heavy, and that water bowls require frequent refilling. We begin to see the systemic consequences of the accumulation of uremic toxins. Uremia refers to the clinical syndrome associated with kidney failure, and while urea itself may not be the primary toxin, it serves as a marker for the retention of numerous other waste products. These toxins affect multiple organ systems. The gastrointestinal tract is particularly affected. Uremic gastritis develops as urea is broken down by bacterial ureas in the stomach and oral cavity, producing ammonia. This causes nausea, vomiting, oral ulceration, and halitosis. The characteristic uremic breath has a distinctive ammonia-like odor. Gastric ulceration can lead to hematemesis and melena. Metabolic acidosis develops as the kidneys lose their ability to excrete the daily acid load generated by normal metabolism. The buffering systems become overwhelmed, and blood pH declines. This acidosis contributes to muscle wasting, as amino acids are mobilized from muscle to provide substrate for metabolic buffering. Renal secondary hyperparathyroidism becomes clinically significant in stage 3. As GFR declines, phosphorus excretion diminishes, leading to hyperphosphatia. Elevated phosphorus suppresses the synthesis of calcitriol, the active form of vitamin D, which is produced in the kidneys. Low calcitriol levels reduce intestinal calcium absorption, causing hypocalcemia. The parathyroid glands respond to the hypocalcemia by increasing secretion of parathyroid hormone. While this helps normalize serum calcium, chronically elevated PTH has numerous detrimental effects, including promotion of renal fibrosis. Anemia becomes more pronounced in stage 3 as the production of erythropoietin by the damaged kidneys diminishes. Erythropoietin is the primary hormone regulating red blood cell production. Reduced erythropoietin leads to decreased erythropoiesis in the bone marrow, resulting in a normocytic, normochromic, non-regenerative anemia. This anemia contributes to lethargy, weakness, and decreased quality of life. Stage 4: severe azotemia and uremic crisis. Finally, we reach stage 4: severe renal azotemia. Creatinine concentrations exceed 440 micromoles per liter, or 5 milligrams per deciliter. These patients are at high risk for uremic crisis, a life-threatening condition requiring immediate and aggressive intervention. The systemic effects are profound, involving the gastrointestinal, cardiovascular, and central nervous systems. In the gastrointestinal system, severe uremic gastroenteritis can cause intractable vomiting and diarrhea, leading to dehydration and electrolyte derangements that further compromise renal perfusion. Gastric ulceration may perforate, resulting in peritonitis. The combination of nausea and oral ulceration causes complete anorexia, necessitating nutritional support through feeding tubes. Cardiovascular complications in stage 4 include uremic pericarditis, where uremic toxins irritate the pericardium, causing inflammation and potential pericardial effusion. Systemic hypertension, if not already present in earlier stages, often becomes severe. Volume overload can occur if fluid intake exceeds the kidney's diminished ability to produce urine, leading to pulmonary edema and dyspnea. The central nervous system manifestations of uremia include depression, stupor, seizures, and in extreme cases, coma. These neurological signs reflect the toxicity of accumulated waste products on neural tissue. Peripheral neuropathy, though less common in cats than in humans with end-stage renal disease, can occasionally be observed. The focus of management shifts from slowing progression to intensive palliative and supportive care. At this stage, dialysis or renal transplantation may be considered in select cases, though these options are not available in all geographic locations and carry significant financial and logistical considerations. For most stage 4 patients, management involves hospitalization, intravenous fluid therapy, antiemetics, gastroprotectants, phosphate binders, appetite stimulants, and when appropriate, discussions regarding quality of life and humane euthanasia. Unit conversion. Ensuring global standardization. To ensure precision in our clinical records, we must be fluent in the conversion between SI units and US conventional units. While many automated analyzers report in one or the other, the IRIS guidelines provide both to facilitate global standardization. The scientific community has increasingly moved toward SI units, which are based on molar concentrations, but many laboratories, particularly in the United States, continue to report in conventional units of mass per volume. We shall now go through each stage-specific range, converting micromoles per liter to milligrams per deciliter, using the standard conversion factor of 0.0113. This conversion factor is derived from the molecular weight of creatinine, which is 113.12 grams per mole. To convert from micromoles per liter to milligrams per deciliter, we multiply by the molecular weight and adjust for the unit difference, yielding the factor of 0.0113. For stage 1, the creatinine concentration is defined as less than 140 micromoles per liter. This converts to less than 1.6 milligrams per deciliter. Let us work through this calculation step by step. We take the value of 140 micromoles per liter and multiply by 0.0113. This yields 1.582 milligrams per deciliter, which the IRIS guidelines round to 1.6 milligrams per deciliter for simplicity. It is important to repeat these values for the purpose of memorization and clinical fluency. 140 micromoles per liter is equivalent to 1.6 milligrams per deciliter. A cat at 130 micromoles per liter would be at approximately 1.47 milligrams per deciliter, remaining safely within stage 1. If we encounter a value of 120 micromoles per liter, this converts to 1.36 milligrams per deciliter, also stage 1. For stage 2, the range begins at 140 micromoles per liter and extends to 250 micromoles per liter. Converting the lower boundary, as we have already established, 140 micromoles per liter is 1.6 milligrams per deciliter. Converting the upper boundary, 250 micromoles per liter, requires us to multiply by our conversion factor. 250 times 0.0113 equals 2.825 milligrams per deciliter, which is rounded to 2.8 milligrams per deciliter. Therefore, stage 2 is defined as the range between 1.6 and 2.8 milligrams per deciliter. If a laboratory reports a value of 200 micromoles per liter, the converted value is 2.26 milligrams per deciliter, placing the patient firmly in the middle of stage 2. Similarly, a value of 170 micromoles per liter converts to 1.92 milligrams per deciliter, which is in the lower portion of stage 2 but still definitively classified as mild azotemia. For stage 3, the moderate azotemia range begins at 251 micromoles per liter and concludes at 440 micromoles per liter. In US conventional units, 251 micromoles per liter is 2.9 milligrams per deciliter. We can verify this. 251 times 0.0113 equals 2.836, which rounds to 2.9. The upper limit of 440 micromoles per liter converts to 5.0 milligrams per deciliter. The calculation: 440 times 0.0113 equals 4.972, rounded to 5.0. To repeat, the stage 3 window is 2.9 to 5.0 milligrams per deciliter. A value of 350 micromoles per liter converts to 3.96 milligrams per deciliter. This places the patient in the mid to upper range of stage 3, indicating moderate azotemia with significant renal dysfunction. A value of 300 micromoles per liter converts to 3.39 milligrams per deciliter, representing the lower middle portion of stage 3. Finally, for stage 4, any value exceeding 440 micromoles per liter is classified as severe azotemia. As we have noted, 440 micromoles per liter is 5.0 milligrams per deciliter. Any value above 5.0 milligrams per deciliter, for instance, a value of 600 micromoles per liter, which converts to 6.78 milligrams per deciliter, represents the most advanced stage of chronic kidney disease. A value of 800 micromoles per liter, which might be encountered in a cat presenting in uremic crisis, converts to 9.04 milligrams per deciliter. Such values indicate profound renal failure and carry a grave prognosis without aggressive intervention. We will now repeat these 4 thresholds once more for clarity and to facilitate their retention in long-term memory. Stage 1. Less than 1.6 milligrams per deciliter. Stage 2. 1.6 to 2.8 milligrams per deciliter. Stage 3. 2.9 to 5.0 milligrams per deciliter. Stage 4. Greater than 5.0 milligrams per deciliter. Note how these thresholds differ significantly from the canine iris stages, which utilize lower creatinine cutoffs due to different physiological norms. Dogs, particularly large breed dogs with greater muscle mass, typically have higher creatinine values than cats at equivalent levels of renal function. In the feline patient, we must adhere strictly to these higher brackets, and extrapolation from canine reference ranges is inappropriate. Observe the transition points between these 4 stages. Note specifically the narrow range of stage 2 compared to the broader range of stage 3. Stage 2 spans 1.2 milligrams per deciliter from 1.6 to 2.8, while stage 3 spans 2.1 milligrams per deciliter from 2.9 to 5.0. This reflects the accelerating nature of renal decline as the functional reserve is depleted. The curvilinear relationship between GFR and creatinine means that small changes in GFR produce larger changes in creatinine as we move into more advanced disease. Symmetric dimethylarginine, biology and clinical utility. We now transition our focus to a relatively modern advancement in renal diagnostics, symmetric dimethylarginine, commonly known by its abbreviation SDMA. This biomarker has revolutionized our approach to early detection of kidney disease and has been incorporated into the IRIS guidelines as a complementary marker to creatinine. To understand the clinical utility of SDMA, we must first understand its biological origin and the biochemical pathways that govern its production and elimination. SDMA is a methylated form of the amino acid L-arginine. More specifically, it is one of several dimethylated arginine residues that can be produced in mammalian cells. It is produced within the nucleus of every nucleated cell in the feline body, making its production independent of any single organ system or tissue type. This production is a result of the post-translational modification of proteins by an enzyme group known as protein arginine methyltransferases, or PRMTS. These enzymes methylate arginine residues on various proteins after the proteins have been synthesized by the ribosome. Specifically, SDMA is formed through the type 2 PRMT pathway, which adds two methyl groups to the same nitrogen atom on the arginine side chain, creating a symmetric configuration. This is distinct from asymmetric dimethylarginine, or ADMA, which is also produced in cells but is partially metabolized by the enzyme dimethylarginine dimethylaminohydrolase, or DDAH, before excretion. SDMA, however, is not a substrate for DDAH and therefore is not metabolized within the body. Unlike many other metabolic byproducts, SDMA is produced at a remarkably constant rate. Its production rate is not influenced by diet, inflammatory processes, or, crucially for our purposes, muscle mass. This constancy is what makes SDMA such a valuable biomarker. Once produced, SDMA is released into the systemic circulation upon the natural breakdown of these intracellular proteins. As proteins undergo turnover, a process that occurs continuously in all cells, the methylated arginine residues are liberated. Because it is a small, water-soluble molecule with a molecular weight of approximately 202 daltons, it is eliminated almost exclusively by the kidneys through glomerular filtration. SDMA is freely filtered at the glomerulus and is not significantly reabsorbed or secreted by the renal tubules. Therefore, its concentration in the blood is directly inversely proportional to the glomerular filtration rate. As the GFR declines, the concentration of SDMA rises in a predictable manner. This relationship is more linear than the relationship between creatinine and GFR, which provides certain analytical advantages. SDMA versus creatinine, the muscle mass problem. Let us examine why SDMA has become a cornerstone of the IRIS guidelines and why it addresses one of creatinine's most significant limitations. As we discussed in the previous segment, creatinine is a byproduct of muscle metabolism, specifically derived from the non-enzymatic breakdown of creatine and phosphocreatine in muscle tissue. A geriatric cat with significant muscle wasting, a common occurrence in chronic kidney disease due to metabolic acidosis, poor nutrition, and the catabolic effects of uremia, may have a falsely low creatinine level because there is simply less muscle mass to produce it. This phenomenon is sometimes referred to as sarcopenia, and it is particularly prevalent in cats with concurrent hyperthyroidism, diabetes mellitus, or neoplastic disease. Let us consider a clinical example to illustrate this problem. Imagine two cats, both with identical GFR values of 40 milliliters per minute per kilogram, a value representing approximately 60% loss of renal function. Cat A is a young, muscular, 4-year-old Maine Coon weighing 6 kilograms with excellent body condition. Cat B is a 15-year-old domestic shorthair weighing 3 kilograms with severe muscle wasting and a body condition score of 2 out of 9. Cat A, with its substantial muscle mass, may have a creatinine of 280 micromoles per liter, placing it clearly in IRIS stage 3. Cat B, despite having the same GFR and the same degree of renal dysfunction, may have a creatinine of only 160 micromoles per liter due to reduced muscle mass, which would classify it as only IRIS stage 2. This discrepancy can lead to an underestimation of the severity of the disease, or what we call a false negative for azotemia, and may result in delayed or inadequate therapeutic intervention. SDMA bypasses this limitation entirely. Because it is produced by all nucleated cells throughout the body, rather than specifically by muscle tissue. A sarcopenic, thin cat and a well-muscled, athletic cat will have their renal function assessed on an equal playing field. Both cats in our hypothetical example would likely have SDMA values in the range of 30 to 35 micrograms per deciliter, clearly indicating stage 3 disease regardless of their muscle mass. This makes SDMA particularly valuable in populations at high risk for muscle wasting, including geriatric cats, cats with concurrent chronic diseases, and cats that have been experiencing prolonged anorexia or cachexia associated with their kidney disease. SDMA thresholds and iris integration. In the updated iris guidelines, which were revised to include SDMA in 2015 and have been refined in subsequent years, SDMA thresholds are used to refine the stage assigned by creatinine. For a cat to be considered normal or stage 1 without other evidence of renal pathology, the SDMA should be less than 14 micrograms per deciliter. This value of 14 micrograms per deciliter represents the upper limit of the reference interval established through studies of healthy feline populations. If a cat's creatinine suggests stage 1, but their SDMA is persistently above 14 micrograms per deciliter, the clinician must consider the patient to be in an early state of renal decline, even if creatinine remains reassuringly within normal limits. If the SDMA is between 18 and 25 micrograms per deciliter, this generally correlates with iris stage 2. These values indicate that GFR has declined to a level consistent with mild azotemia, even if creatinine has not yet risen proportionately. A value between 26 and 38 micrograms per deciliter correlates with stage 3, indicating moderate renal dysfunction. Any value exceeding 38 micrograms per deciliter indicates stage 4, representing severe renal failure. These SDMA thresholds were established through clinical studies comparing SDMA concentrations with measured GFR using gold standard techniques such as iohexyl clearance. The correlation between SDMA and GFR has been demonstrated to be strong, with correlation coefficients typically exceeding 0.8 in most published studies. The SDMA override protocol. We must now address the SDMA override protocol in detail, as this represents one of the most important practical applications of this biomarker. If a cat is in a specific iris stage based on creatinine, but the SDMA is disproportionately high, the guidelines suggest that the patient should be treated as if they are in the higher stage indicated by the SDMA value. For example, if a cat's creatinine is 180 micromoles per liter, placing it in stage 2, but its SDMA is 30 micrograms per deciliter, which is a stage 3 value, the clinician should manage the cat according to stage 3 protocols. This means implementing more aggressive dietary phosphorus restriction, considering the use of intestinal phosphate binders, potentially initiating ACE inhibitor therapy if proteinuria is present, and monitoring the patient more frequently. This upstaging is particularly vital in the feline patient, where weight loss and muscle atrophy often mask the rise of creatinine. It ensures that we are not providing false reassurance based on an artificially low creatinine value, and that we are implementing appropriate therapeutic interventions at the stage of disease where they are most likely to be beneficial. To repeat the primary threshold, 14 micrograms per deciliter. 1-4. This is the point at which our clinical suspicion must rise. Any persistent value of 15, 16, or 17 micrograms per deciliter warrants further investigation into the urine-specific gravity and the presence of proteinuria, even if the creatinine remains at 110 micromoles per liter. It is worth noting that SDMA measurements should also be performed on samples from fasted, clinically stable patients, and ideally confirmed with a second measurement 2 to 4 weeks later, following the same principles we apply to creatinine staging. Transient elevations can occur, though they are less common with SDMA than with creatinine. Mathematical analysis of creatinine SDMA discrepancies. We shall now perform a detailed audit of the mathematical discrepancies between creatinine and SDMA, specifically focusing on the criteria for upstaging a feline patient. The IRIS guidelines state that if SDMA is disproportionately increased relative to creatinine, the SDMA value should take precedence. This is the override protocol, and understanding when and how to apply it is essential for appropriate patient management. The fundamental principle underlying the override protocol is this: when two biomarkers disagree, we should give greater weight to the biomarker that is less influenced by non-renal factors. In the case of creatinine versus SDMA, the SDMA is considered more reliable when there is a discrepancy, because it is not affected by muscle mass, age, body condition, or breed in the way that creatinine is. Let us consider clinical scenario alpha in extensive detail. A 10-year-old domestic shorthair presents with a stable fasting creatinine of 180 micromoles per liter. This value, 180, places the cat in the lower half of stage 2, which, as you recall, ranges from 140 to 250 micromoles per liter. If we convert this to conventional units, 180 times 0.0113 equals 2.03 milligrams per deciliter, which is comfortably within the stage 2 bracket of 1.6 to 2.8 milligrams per deciliter. However, the concurrent SDMA measurement is reported at 32 micrograms per deciliter. We must analyze this discrepancy carefully. A value of 32 micrograms per deciliter for SDMA falls within the stage 3 bracket, which begins at 26 and ends at 38 micrograms per deciliter. Because 32 is a stage 3 value and 180 is a stage 2 value, we have what we call a disproportionate results matrix, a situation where the two biomarkers are not in agreement regarding disease stage. Following the IRIS logic, we ignore the stage 2 creatinine classification and officially designate this patient as IRIS stage 3. The math dictates that the more sensitive biomarker, the methylated arginine, reveals a level of nephron loss that the muscle-dependent creatinine is failing to register. This patient likely has reduced muscle mass, possibly due to age-related sarcopenia, chronic illness, or the early catabolic effects of kidney disease itself, which is causing the creatinine to underestimate the true severity of renal dysfunction. From a clinical management perspective, this upstaging is significant. A stage 2 patient might be managed with dietary modification alone, while a stage 3 patient requires more aggressive intervention. We would initiate or intensify phosphorus restriction, potentially add intestinal phosphate binders if serum phosphorus is elevated, monitor blood pressure more closely, and increase the frequency of recheck examinations from every 6 months to every 3 to 4 months. Now, let us consider clinical scenario beta with equal rigor. A 15-year-old Siamese with significant sarcopenia presents with a creatinine of 120 micromoles per liter. This is a stage 1 value, as it is below the 140 micromoles per liter threshold. Converting to conventional units, 120 times 0.0113 equals 1.36 milligrams per deciliter, well below the stage 2 threshold of 1.6 milligrams per deciliter. However, the SDMA is recorded at 22 micrograms per deciliter. We must evaluate the significance of this value. 22 micrograms per deciliter is firmly within the stage 2 range of 18 to 25 micrograms per deciliter. Here, the math reveals a false stage 1 classification if we were to rely on creatinine alone. The cat's lack of muscle mass has artificially depressed the creatinine to 120 micromoles per liter. In a cat with normal muscle mass and this same degree of renal dysfunction, we might expect a creatinine of 170 or 180 micromoles per liter. If we relied solely on creatinine, we would fail to implement stage 2 management. We might not recommend dietary modification, we would not monitor as closely, and we would miss an opportunity for early intervention. By applying the override protocol, we move the patient from stage 1 to stage 2. The difference of 20 micromoles per liter between the measured creatinine of 120 and the stage 2 threshold of 140 is mathematically outweighed by the 4 microgram per deciliter elevation of SDMA above the 18.0 threshold for stage 2. This Siamese cat should be placed on a renal support diet. We should investigate for proteinuria and hypertension, and we should monitor creatinine and SDMA every 3 to 6 months to track progression. Without the SDMA measurement, this patient's kidney disease would have gone undetected, and therapeutic intervention would have been delayed. Finally, consider clinical scenario gamma, involving the transition to stage 4. A patient presents with a creatinine of 400 micromoles per liter. This is a high stage 3 value, nearing the 440 micromoles per liter threshold for stage 4. Converting to conventional units, 400 times 0.0113 equals 4.52 milligrams per deciliter, which is in the upper range of stage 3 but not yet stage 4. However, the SDMA is 45 micrograms per deciliter. Since 45 exceeds the stage 4 threshold of 38 micrograms per deciliter, the patient is mathematically upstaged to stage 4. This upstaging has profound implications. Stage 4 patients require intensive management, including consideration for hospitalization, aggressive antiemetic therapy, intravenous fluid support, and frank discussions with the owner regarding prognosis and quality of life. If we relied on the creatinine value alone, we might manage this patient as an upper stage 3, perhaps without patient care and oral medications. The SDMA value reveals that the degree of renal dysfunction is actually more severe, and the patient is at imminent risk for uremic crisis. To summarize the override logic with absolute clarity, if creatinine says stage 2, but SDMA says stage 3, the answer is stage 3. If creatinine says stage 3, but SDMA says stage 4, the answer is stage 4. If creatinine says stage 1, but SDMA says stage 2, the answer is stage 2. The SDMA takes precedence in all cases of discrepancy, assuming both measurements are from properly collected samples in a fasted, clinically stable patient. It is worth noting that the reverse situation, where creatinine suggests a higher stage than SDMA, is less common but can occur. In such cases, the clinician should consider whether there are non-renal factors artificially elevating creatinine, such as dehydration, gastrointestinal bleeding with absorption of blood proteins, or laboratory error. Repeating both measurements after addressing any reversible factors is appropriate. SDMA and GFR, the early detection advantage. We will now begin a recitation of the relationship between SDMA and GFR percentage loss, as this represents one of the most compelling advantages of this biomarker. When GFR has decreased by 25%, meaning that 1/4 of the functional renal mass has been lost, SDMA typically begins its initial ascent above the reference interval of 14 micrograms per deciliter. This is significantly earlier than creatinine, which often remains stable until a 40% or even 50% loss of GFR has occurred. To put this in concrete terms, in a cat that has lost 30% of its renal function, SDMA may already be elevated to 16 or 17 micrograms per deciliter, while creatinine might still be 120 or 130 micromoles per liter, firmly within the reference interval. Thus, SDMA provides a wider diagnostic window for intervention. This expanded window is clinically invaluable because many of the interventions we employ in chronic kidney disease, dietary modification, blood pressure control, management of proteinuria, are most effective when initiated early, before extensive irreversible damage has occurred. Studies examining the sensitivity of SDMA for detecting early kidney disease have shown that it can identify renal dysfunction months to years before creatinine becomes elevated. In one study of geriatric cats followed longitudinally, SDMA elevation preceded creatinine elevation by an average of 17 months. This represents a substantial period during which therapeutic interventions could be implemented. The kinetics of SDMA elimination also offer advantages. Because SDMA is eliminated exclusively by glomerular filtration without significant tubular reabsorption or secretion, its concentration is a more direct reflection of filtration capacity. Creatinine, while primarily eliminated by glomerular filtration, does undergo a small amount of tubular secretion in cats, which can introduce variability. Furthermore, SDMA concentrations are not influenced by the time of day, recent exercise, or dietary protein intake in the acute sense. Creatinine can show diurnal variation and may be transiently affected by consumption of meat-based meals, though this effect is generally minor in cats compared to humans. Substaging, proteinuria assessment. Having established the primary iris stage through the analysis of creatinine and SDMA, we must now proceed to substaging. Substaging is not merely a secondary classification. It is the process by which we identify the two most significant risk factors for the progression of chronic kidney disease: proteinuria and systemic hypertension. These two parameters are independent predictors of disease progression and mortality, and their management can substantially alter the trajectory of kidney disease. We begin with the assessment of proteinuria. In the feline patient, we utilize the urine protein to creatinine ratio, or UPC. This ratio allows us to quantify protein loss while accounting for variations in urine concentration, which is essential because random urine samples can vary widely in their concentration depending on the patient's hydration status and the kidney's current concentrating ability. The UPC is calculated by measuring the concentration of protein in the urine and the concentration of creatinine in the same urine sample, then dividing the protein concentration by the creatinine concentration. When both are measured in the same units, the ratio is unitless. This ratio correlates well with 24-hour urine protein excretion, which is the gold standard for quantifying proteinuria but is impractical to perform in clinical practice due to the difficulty of collecting complete 24-hour urine samples from cats. It is important to perform the UPC on a urine sample with a quiet, non-inflammatory sediment to ensure the protein is of renal origin rather than from lower urinary tract inflammation, hemorrhage, or infection. A urine sample with significant hematuria, puria, or bacteriuria should not be used for UPC determination until the underlying inflammatory or infectious process has been treated and resolved. The presence of red blood cells, white blood cells, or bacteria in the urine can contribute protein that is not related to glomerular or tubular dysfunction. Therefore, before attributing proteinuria to kidney disease, we must perform a complete urinalysis including sediment examination and, when indicated, urine culture. If active sediment is present, we treat the underlying condition, whether it be bacterial cystitis, urolithiasis, or idiopathic cystitis, and then recheck the UPC after resolution. The UPC categories for cats are defined by 3 distinct numerical brackets that have been validated through clinical studies examining outcomes in cats with chronic kidney disease. A cat is considered non-proteinuric if the UPC ratio is less than 0.2. Please note the value, 0.2 or 0.2. If the ratio falls between 0.2 and 0.4, the patient is classified as borderline proteinuric. If the ratio exceeds 0.4, the patient is classified as proteinuric. We shall now perform an audit of these 3 thresholds with careful attention to the decimal points. 0.2, 0.4. Less than 0.2 is non-proteinuric. 0.2 to 0.4 is borderline. Greater than 0.4 is proteinuric. Let us work through some examples to solidify our understanding. A cat with a UPC of 0.15 is non-proteinuric. A cat with a UPC of 0.3 is borderline proteinuric. A cat with a UPC of 0.6 is proteinuric. A cat with a UPC of 1.2 is severely proteinuric. The presence of persistent proteinuria is a strong negative prognostic indicator in feline chronic kidney disease. Multiple studies have demonstrated that cats with higher UPC ratios have shorter survival times and faster progression to end-stage renal disease compared to cats with similar IRA stages but lower levels of proteinuria. Each incremental increase in the UPC ratio correlates with an increased risk of uremic crisis and renal-related mortality. The mechanism by which proteinuria contributes to progression is multifactorial. The passage of excessive protein through the glomerulus can directly damage the glomerular filtration barrier, leading to progressive glomerulosis. Protein that enters the tubular lumen and is reabsorbed by tubular epithelial cells can trigger inflammatory cascades and interstitial fibrosis. Therefore, a stage 2 cat that is proteinuric, with a UPC greater than 0.4, often carries a more guarded prognosis than a stage 2 cat that is non-proteinuric with a UPC less than 0.2, even though both cats have the same creatinine and SDMA values. This is why the substaging is not merely academic but has real prognostic and therapeutic implications. For cats in the borderline proteinuric category, with UPC values between 0.2 and 0.4, we recommend repeating the measurement in 2 to 4 weeks to determine if the proteinuria is persistent or transient. Transient proteinuria can occur with stress, fever, strenuous exercise, or seizures. Only persistent proteinuria, confirmed on multiple samples, is considered clinically significant for iris substaging. When we identify persistent proteinuria in a cat with chronic kidney disease, further characterization is warranted. We should determine whether the proteinuria is primarily glomerular or tubular in origin. Glomerular proteinuria typically involves the loss of larger molecular weight proteins, particularly albumin, and results in higher UPC ratios. Tubular proteinuria involves the loss of smaller proteins and typically produces lower UPC values. While specialized testing such as urine protein electrophoresis can differentiate these, it is not always necessary in clinical practice. What is essential is that we recognize proteinuria as a treatable risk factor and initiate appropriate therapy. Management of proteinuria. The management of proteinuria in cats with chronic kidney disease centers on the use of drugs that inhibit the renin-angiotensin-aldosterone system, or RAAS. The two primary drug classes are ACE inhibitors, angiotensin-converting enzyme inhibitors, and ARBS, angiotensin receptor blockers. ACE inhibitors such as benazepril or enalapril work by blocking the conversion of angiotensin I to angiotensin II. Angiotensin II is a potent vasoconstrictor that preferentially constricts the efferent arteriole of the glomerulus, increasing intraglomerular pressure. By reducing angiotensin II production, ACE inhibitors decrease intraglomerular hypertension, which reduces the driving force for protein filtration. ARBS such as telmisartan work by blocking the angiotensin II type 1 receptor, preventing angiotensin II from exerting its effects even if it is still being produced. The net result is similar to that of ACE inhibitors: reduced intraglomerular pressure and reduced proteinuria. Clinical trials in cats have demonstrated that both ACE inhibitors and ARBs can reduce UPC ratios by 30 to 50% in cats with proteinuric chronic kidney disease. This reduction in proteinuria may slow the rate of disease progression, though definitive evidence that these drugs extend survival in cats is still being accumulated. When initiating RAAS blockade, we must monitor renal function carefully. A small increase in creatinine, typically 10 to 20%, is expected and acceptable, as it reflects the reduction in intraglomerular pressure. However, a rise in creatinine exceeding 25 to 30% suggests oversuppression of glomerular filtration and may necessitate dose reduction or discontinuation. Substaging: systemic hypertension. We now turn our attention to the second substaging category, systemic hypertension. The measurement of systolic blood pressure is a fundamental component of the comprehensive renal examination, yet it is often overlooked in general practice due to time constraints, lack of equipment, or unfamiliarity with proper technique. Hypertension in cats with chronic kidney disease is both a consequence of the kidney disease and a contributor to its progression. The damaged kidneys have impaired sodium excretion and dysregulated renin-angiotensin-aldosterone system activity, both of which can lead to increased blood pressure. Conversely, systemic hypertension can cause progressive renal damage through glomerular hyperfiltration and vascular injury. IRIS classifies hypertensive risk based on the likelihood of target organ damage, specifically damage to the eyes, the brain, the heart, and the kidneys themselves. The eyes are particularly vulnerable in cats, and hypertensive retinopathy can lead to retinal detachment and acute blindness, which is often one of the presenting signs that prompts investigation and diagnosis of hypertension. The brain can suffer hypertensive encephalopathy, manifesting as altered mentation, seizures, or behavioral changes. The heart undergoes hypertrophic remodeling in response to chronic pressure overload, which can eventually lead to diastolic dysfunction and congestive heart failure. The kidneys experience progressive glomerulosis and arteriolosclerosis, accelerating the decline in function. The blood pressure categories are divided into 4 levels of risk, numbered 1 through 4. Category 1 is minimal risk. This is defined by a systolic blood pressure of less than 140 millimeters of mercury. At this level, the risk of target organ damage is considered very low, and no specific antihypertensive therapy is required, though monitoring should continue. Category 2 is mild risk. This involves a systolic pressure between 140 and 159 millimeters of mercury. At this level, there is a mild risk of target organ damage. The decision to initiate therapy depends on the presence of concurrent proteinuria, the IRIS stage, and whether there is any evidence of subclinical target organ damage such as mild retinal changes. Category 3 is moderate risk. This range covers 160 to 179 millimeters of mercury. At this level, the risk of target organ damage is significant, and antihypertensive therapy is generally recommended. We should investigate for evidence of target organ damage, including a thorough fundic examination and assessment for cardiac abnormalities. Finally, Category 4 is severe risk. This is any systolic pressure equal to or greater than 180 millimeters of mercury. At this level, the risk of target organ damage is very high, particularly the risk of acute hypertensive retinopathy and retinal detachment. These patients require urgent antihypertensive therapy, often initiated the same day as diagnosis. Let us repeat these numerical thresholds for the purpose of memorization and clinical application. 140 millimeters of mercury. 160 millimeters of mercury. 180 millimeters of mercury. Less than 140 is minimal risk. 140 to 159 is mild risk. 160 to 179 is moderate risk. 180 and above is severe risk. It is critical to remember that a diagnosis of hypertension should ideally be based on multiple measurements taken in a calm environment to account for the white coat effect, a transient rise in blood pressure due to the stress of the clinical setting. Cats are particularly prone to stress-induced hypertension, and a single elevated reading in an anxious cat should not immediately result in lifelong medication. The recommended protocol is to obtain at least 3 to 5 consecutive measurements, discarding the first measurement as the cat acclimates to the procedure, and then averaging the remaining values. If possible, measurements should be taken in a quiet examination room with minimal stimulation, allowing the cat time to settle before beginning. Various devices can be used for blood pressure measurement in cats, including Doppler ultrasonic methods and oscillometric devices. Each has advantages and limitations. Doppler systems are considered more reliable in cats but require more technical skill. Oscillometric devices are easier to use but may be less accurate in small or uncooperative patients. If a cat presents with a systolic pressure of 170 millimeters of mercury on multiple measurements taken under appropriate conditions, it is classified as substage AP3, indicating a moderate risk of target organ damage. The AP designation stands for arterial pressure, and the number corresponds to the risk category. Synthesis of iris staging and clinical communication. We must now consider the synthesis of these findings into a complete iris classification that communicates maximum information in a standardized format. A complete iris diagnosis for a patient might sound like this: iris stage 2, non-proteinuric, with severe risk of hypertension. This tells us that the cat has mild azotemia based on creatinine and SDMA, no significant proteinuria with a UPC less than 0.2, but has systolic blood pressure equal to or exceeding 180 millimeters of mercury. Or perhaps the diagnosis reads, iris stage 3, proteinuric, with minimal risk of hypertension. This indicates moderate azotemia, significant proteinuria with a UPC greater than 0.4, but normal blood pressure below 140 millimeters of mercury. Each component of this classification has therapeutic implications. The primary stage, determined by the previously discussed biomarkers of creatinine and SDMA, dictates the intensity of dietary management, the frequency of monitoring, and the overall prognostic outlook. The proteinuria substage determines whether we should initiate RAAS blockade with an ACE inhibitor or ARB. A cat that is non-proteinuric does not require these medications for renal protection, though they may be indicated for other reasons such as congestive heart failure. A cat that is borderline proteinuric should be monitored closely and may benefit from therapy if the UPC trends upward. A cat that is proteinuric should be started on antiproteinuric therapy unless contraindications exist. The hypertension substage determines whether we should initiate antihypertensive therapy, most commonly with calcium channel blockers such as amlodipine mesylate. Amlodipine is the first-line antihypertensive agent in cats due to its efficacy, safety profile, and once-daily dosing convenience. A cat with minimal or mild hypertensive risk may not require medication, though we should monitor blood pressure regularly. A cat with moderate risk should generally be treated. A cat with severe risk requires immediate therapy and close monitoring for target organ damage, particularly fundic examination for retinal changes. The combination of the primary stage with these two substages provides the clinician with a comprehensive roadmap for intervention. It allows for individualized patient management based on the specific constellation of abnormalities present. Consider two different cats, both classified as iris stage 2. Cat A is IRIS stage 2, non-proteinuric, minimal hypertensive risk. This cat requires dietary modification with a renal support diet, monitoring every 4 to 6 months, and client education regarding the disease process. The prognosis is relatively favorable, as the cat has mild azotemia without the major risk factors for rapid progression. Cat B is IRIS stage 2, proteinuric, severe hypertensive risk. Despite having the same creatinine and SDMA values as Cat A, this patient requires much more aggressive management. Immediate initiation of amlodipine for the severe hypertension, initiation of an ACE inhibitor or ARB for the proteinuria, dietary modification, fundic examination to assess for retinal damage, and close monitoring every 4 to 8 weeks initially to assess response to therapy. The prognosis for Cat B is more guarded due to the presence of these additional risk factors. This illustrates why the substaging is not merely descriptive but fundamentally shapes our clinical approach and our conversations with clients regarding prognosis and expected outcomes. Conclusion and clinical integration. This concludes our extended technical review of renal biomarkers in chronic kidney disease in cats. We have systematically examined the IRIS staging system, its theoretical foundations, its practical application, and the integration of both traditional and modern biomarkers. We have explored the curvilinear relationship between GFR and creatinine, and how this mathematical reality creates a diagnostic blind spot in early disease. We have examined how SDMA addresses the limitations of creatinine by providing a muscle mass-independent assessment of renal function, and we have worked through the override protocol that guides clinical decision-making when these two biomarkers disagree. We have performed detailed unit conversions between SI and conventional units for each IRIS stage, ensuring that clinicians can interpret laboratory results regardless of the reporting format. We have analyzed clinical scenarios demonstrating the practical application of the SDMA override, and we have examined the critical importance of substaging for proteinuria and hypertension. The integration of these biomarkers and staging criteria into clinical practice requires diligence, attention to detail, and commitment to serial monitoring. Chronic kidney disease is a progressive condition, and our goal is not cure but rather slowing progression, maintaining quality of life, and delaying the onset of uremic crisis. Each component of the IRIS classification, the primary stage, the proteinuria substage, and the hypertension substage, represents a modifiable or semi-modifiable risk factor. Through dietary management, pharmacological intervention, and supportive care, we can influence the trajectory of disease in many patients. The evolution of our diagnostic capabilities, particularly with the addition of SDMA to our diagnostic armamentarium, has expanded our ability to detect kidney disease earlier and intervene before extensive irreversible damage occurs. This represents meaningful progress in feline nephrology and offers hope for improved outcomes in this common and challenging disease. As we conclude this technical review, it is important to remember that behind every IRIS stage, every UPC ratio, and every blood pressure measurement is an individual patient and a concerned client. Our role is not merely to assign numbers and stages, but to translate these findings into compassionate, evidence-based care that prioritizes the well-being and quality of life of our feline patients. Thank you for your attention during this session of the Boring Lecture Series. We hope this has been a useful resource for your studies or a supportive environment for your rest. This lecture was narrated by Dr. Owen, an artificial voice for the Boring Lecture Series. For those seeking additional detail beyond the scope of this lecture, further information on chronic kidney disease and azotemia in cats can be found in standard veterinary internal medicine textbooks, dedicated nephrology references, and consensus guidelines. The International Renal Interest Society publishes regularly updated guidelines on the staging and management of chronic kidney disease, which are widely used in both clinical practice and research. Review articles in veterinary internal medicine journals also provide comprehensive discussions of renal physiology, diagnostic approaches, and disease progression. Students are encouraged to consult these sources for more in-depth and technical exploration of the subject. Please see the description for further resources to the primary literature cited throughout this discussion. We will now fade to soothing bioacoustic sounds and drones to allow for a period of quiet reflection or continued rest. Good night.